you've got me and Steph and Liz with you today. We are specialist nurses for organ donation, and we are based in UHL.
Yeah, we've also got, I think Cindy's joined the call as well, who's our clinical lead for organ donation.
Yes, and she'd like to know where you got that bloody photo from.
Oh, yeah, we found, I did ask you several times to send me pictures, Cindy, so then I stalked your Facebook and no, I don't know where it came from actually.
So we're the UHL organ donation team. So Cindy and Ricky, me and Liz, and then Rebecca and Danielle are SRs, and we've just had Adele Nicholson join us from Glenfield. So we'll just talk a little bit about our role. So our role is split into what we do embedded in our office hours and what we do on call. So we have one long day a week, which is embedded hours, which we do teaching, audits, anything around UHL that needs help. We do debriefs, lots of different things. And then when we're on call, we do referrals and assessments to make sure that we are attending appropriate donors. We cover in the Midlands team 26 different hospitals. So on the east side, you've got Nottingham, Leicester, Derby, and then Coventry, Birmingham, going up to Stoke at the top, down to Worcester at the bottom, and then across to Shrewsbury and Telford. So we cover a really big on-call region 24/7. And we will go to whatever donors there are in whatever hospital on whatever. The green line is the current transplant waiting list. So currently we have about 6,200 people on it. It did dip during COVID, but that is like a false negative because a lot of the kidney recipients and different transplant centres closed during the COVID months. So the actual wait officially went down, but it was like a false negative number. And then the red bars are actually our amount of transplants that we do per year. So we haven't quite got back up to our pre-COVID numbers yet, but we're making our way back up. We did still manage to do 2/3 of the donation from our pre-COVID numbers during our COVID year, which is incredible considering the pressures that were on the ITUs at the time. So we audit every single death that happens in ED, ITUs and PICUs around the country, and we've just started auditing the neonatal units as well to look for potential donors. And so this is what we come up with, and this is for the UK for the year 2021-22. So I'll just start from the top and explain it down. So there's 67 million people in the UK. Of those, 620,000 people died in that year, and 370,000 people died in hospital that year. Of those, for the potential donors, potential donors were people that died on an ITU that were stable for the 24-hour period before donation could occur, and that were ventilated. And then of those 6,500, 4,300 were actually referred to the organ donation team as a potential donor. So almost 2,000 people didn't get the opportunity to donate. And then we made donation requests to 2,600 families. So almost 2,000 people weren't actually suitable to be a donor. And of the 2,600, 1,700 families wanted to move forward with donation. And then we did 1,397 donors from the 1,700, which are, some people go down into terminal decline after they've been consented, and some people don't actually have any organs accepted. There's nobody waiting specifically for that gift at that time. So of those 1,300 people, 3,682 organs were transplanted into 3,400 people. So some people had double transplants, which are heart and lungs. They can be liver, bowel, kidneys together, pancreas, or pancreas and kidneys together.
Okay, so probably as most of you know, the types of donation. So the old-fashioned heart-beating donor is the DBD, brainstem death or neurological death. And then the more modern DCD is donation after circulatory death. And we'll talk through a little bit about what your role is with each of these a bit later on in the presentation. So we just advise, as usual, to refer all patients who are ventilated and at the end of their life, and then we don't miss any. The referral line's 24 hours a day. If you can't find the number on a cup or a fork or a random bit of paper around ITU, then you can always find it through the switchboard, so it's always available to you. Talking to families about organ donation, one of the main points is, it's a little quote that our clinical lead Ricky coined, which was the first rule of organ donation is not to talk about it. We're not expecting any of you to talk about it to families at all. There's never that expectation unless a family bring it up with you first. So ideally you'd refer to us rather than bring it up. I think last year in the trust, not just within the ITUs, but we had 14 occasions where nursing staff, police officers, doctors brought up organ donation at the wrong time, often when patients weren't suitable or hadn't accepted futility. So the main point to take away is please don't bring it up. Refer to us and we can look at whether they meet the criteria, whether they're on the register. Maybe we'll have to screen with some of the transplant centres. Often we don't know if patients are suitable. Each transplant centre has a different criteria and that can change on a weekly basis. So it's just good to refer everybody. So the NICE guidelines on how to talk to patients about organ donation. So they recommend this decoupling approach, which you may have heard of before. So it breaks the conversation into two conversations. The first conversation is your futility conversation, where families should understand that death is inevitable or has already occurred. And then they should be allowed sufficient time to absorb this information. And that can sometimes be hours, sometimes a little bit longer. And it's within the second conversation where you introduce end of life options and organ donation. So when you're talking about withdrawal of treatment or neurological death results, or neurological death, sorry, it should be at a different time from discussing organ donation. The two should be decoupled. Obviously, this is textbook and gold standard, and it isn't always possible, and often futility conversations quite quickly flow into, can you tell me, doctor, what's going to happen next? And sometimes it is difficult to avoid these conversations. So it's all about planning and preparation. So when you're going to have your fertility conversation, sometimes it's ideal to have a specialist nurse in organ donation there. And so if the conversation does roll into that, you know, futility and beyond, you've got somebody there already. Quick touch on neurological death testing. The regional lead for organ donation, Dale Gardner, has brought this up recently to say that the testing levels have reduced nationally, and he doesn't really understand why. He's looking into how things have changed. Obviously, we've had quite a few media cases involving questioning the validity of neurological death testing, and he doesn't know whether that's had an impact, whether doctors feel not as confident as they were with testing. It's obviously best practice to undertake neurological death tests if somebody meets the criteria and not just for the purposes of organ donation.
So if a patient has had neurological death testing and is a consented donor, then we will approach the family to join the Signet trial. So it's a national trial research project that we're running, which it came about from a small trial in Helsinki, which showed that a dose of simvastatin appeared to have quite a big impact on the damage of a donor heart pre-transplant. So they patients will either be randomised to have a single dose of simvastatin or not, and they are planning to recruit 2,600 people to the trial, and we've done about 460 so far a year in, which is about on track for what they were hoping for. So just for your awareness, Ricky Bell is the PI. He did send around some slides not long ago, but if you haven't seen the slides for the simvastatin trial, then please get in touch with him. And just be aware that we might ask you to prescribe a dose of 80 milligrams of simvastatin as a one-off dose, should we have a DBD donor that has randomised to that. So when we consent a family, there's kind of four main ways. There's an expressed opt-in, where somebody has either gone on to the organ donor register and opted in, or that they've verbally talked about it with their family. And there's deemed, which is where a patient meets the criteria of having mental capacity to understand the law, is an adult patient, there's no paediatric patients, that they are normally resident in the UK and in England, and that they haven't actually made a decision to their family whether they wanted to opt in or opt out. The other route is more for paediatric patients, so they won't be deemed and they may not have opted in. Children can opt in onto the organ donor register with their parents' consent, and some parents have had that conversation with their children, so they would know what their wishes are. And then there's an expressed opt-out as well, so that's where somebody's gone onto the organ donor register and said, I don't want to do that, or they have verbally talked about it with their family. And if that's their last known decision, then that's what we'll go with. So the organ donor register, so we talk about opting out. So the left-hand side graph is the amount of people that have opted out on the organ donor register. So with this 67 million people in the UK, 2.3 million have opted out in 2022, up to 2022, which works out about 4 or 5%. So it's very, very low, the actual amount of people that have gone on to actually opt out. And sometimes we have a preconceived notion as to why, if, you know, we look at a person and we say, yeah, they've opted out, yeah, religion, faith, you know, lots of different reasons, you know, the amount of, for example, Muslim people in the UK, there's 4 million Muslim people in the UK on the last census, so that isn't all the people, you know, there's a lot of Jewish people that have opted out, there's loads of different people, so it's just to remember that actually the amount of people that have actually physically got and opted out is actually very, very few. And then the right graph is the number of people that have opted in. So at the last count in 2022, there were 27.7 million people that had opted in, which is almost half of the country had actually said yes, they want to do it. So it's just for you to be aware of those figures, really. So what would we ask of you when we have a consented donor? So there's kind of 5 main things that we would need to do. The first would be to speak to the ME or the coroner, which also would include the police, just to, if it's a suspicious death, just to make sure that they're happy and that they have no objection. Sometimes they will give restricted consent. So if somebody had come in with, for example, a chest stabbing, they might say no chest organs, but you can do anything below the diaphragm. So liver, kidneys, pancreas will be okay because the injury is to the chest wall. We'll ask you to order some investigations. So we need a recent chest x-ray, an echo if it's a cardiac donation, and an ECG if it's a cardiac donation. We look to optimise the patient. And when we say optimise the patient, we talk about optimising organs rather than actually trying to make the patient better. So we would ask you to consider putting a central line in. We would request a dose of methylprednisolone, which is 15 milligrams per kilo up to 1 gram. We prefer the use of vasopressin over noradrenaline because it's kinder to the vessels, and also it has DDAVP in it, which means that when the patients are getting a regular infusion of DDAVP, it does decrease the chances of them getting unstable diabetes insipidus, where they have massive diuresis and then they go very cardiovascularly unstable. We would ask you to prescribe the dose of DDAVP ready, just in case they have a couple of hours where they do have a massive diuresis, and if it's in the middle of the night, you guys have gone to A&E or something to review a patient, you're not around, that care can be given straight away. The other thing to say about vasopressin is the dose that we use is, when you look at your prescribing charts, is the dose for the consultant only agreement. So we go up to how many units per kilo? It's the high dose. I can't remember what it is.
8.
But it's the high dose that we would normally use. And then lung optimization, so regular NEBs, physio if needed, and then potentially some recruitment maneuvers as well if we're doing lung donation. And sometimes a bronchoscopy would be beneficial if it is a lung donor, just to clear any mucus plugs, any debris if they've aspirated. We'll order lots of blood tests to look at the function of organs. Sometimes we'll ask for blood cultures if we're spiking temperatures, if the white cells are going up, etc. The cultures are mainly for the recipients, so we will look at them post donation and then pass those on to the recipient coordinators so they can give antibiotics to the recipients should they need to, if any positive cultures come back. And then we'll do a group and save just to confirm a group, because that's what we do the offering sequence on. And sometimes we need blood cross matched as well. So sometimes in cardiac donation, they will need to have a blood transfusion, but we will again advise you on that. And then documentation, just making sure that the neurological death documentation is all correct. You'll be surprised how many times it's not. The futility conversation, so just making sure that you've written that we're planning to withdraw care on this patient, for examples, extubating and stopping inotropes, and then to proceed to organ donation if they die in the correct time frame. And that bit of documentation is shown to the transplant teams who come, just to make sure that they know and that they can confirm that that is your plan for them to actually have a withdrawal of care and to go for organ donation. We just ask that you document the ME's conversation or the coroner's, or if it's not required, just document that it's not required. It's something, again, that the transplant teams need to see. We'll ask you just to have a look at the ECG and chest x-ray, just write a little review of that, and then making sure that there's no COVID concerns as well. And that's it. Simple. So we've talked about DBD donors a lot, so we'll just look at DCD donors. So that's donation after cardiac death, and the differences. So when you do donation after cardiac death, there's a little bit of planning that needs to be done in before you do withdrawal. So that can be where we're going to do it. So if we're at the Royal, we would generally do it in the anaesthetic room, just from where ITU is compared to where we wouldn't want to run somebody around that distance very quickly. On Glenfield, it's a little bit different with it being a little bit closer. So looking at where we're going to do it and looking at what we're going to do for them. So it would be normal end of life care, which might be starting morphine and midazolam, things like that, and just kind of planning everything beforehand, making sure we've got enough medicines in the syringes to last 3 hours, which will be our stand down time for actually doing organ donation after extubation, and then making sure we've got the right doctor available to accompany us around to the anaesthetic room and a bedside nurse as well. So immediately prior to withdrawal, we'd just confirm, so usually the theatre team would just like to, the lead surgeon just wants to just make sure that they're happy, that you're happy with everything, that when you're going to certify them, how it's going to go, which I'll talk about in a minute. and just making sure that you've got no concerns just before the family come around as well. During withdrawal, you don't have to do a lot. It's just stand in the background, just being close by. And what we will do is we will relay the observations round to the theatre team. We will do kind of 5-minute observations looking at mainly the saturations and the blood pressure, to what point you get warm ischemic time for the organs. So once they go to asystole, this is the biggest part of your role. So we use asystole from the arterial line, not from the ECG trace, because when you've lost the pulsatile flow from the arterial line, you can still have PEA rhythm on the ECG, but you have no pulsatile flow, you have no output. So asystole is confirmed when you've lost the actual arterial trace, which sounds a bit complicated, but it does make sense when you're in the situation. Once that's stopped, we start a 5-minute timer, and during that 5 minutes, that's when we would ask you to listen for breathing and feel for a pulse and confirm that there's no pulsatile flow. At the 5-minute mark, you will then do cranial reflex, dilated pupils and supraorbital pressure, and confirm your 5 things that yes, they have actually died. And after that 5 minutes is up, that's when we take them quickly into the theatre, transfer them over quickly, and then the theatre team will say who has certified this person, and you will say me, hopefully. So we have to do it very quickly, because once blood stops flowing, it starts to create clots in the organs, and we need to perfuse the organs very, very quickly to reduce the ischemic damage and to get rid of any clots, which make them a better gift to carry on giving. So it has to be done quite quickly. But we have a lovely form that we use, which is very simple. Yeah.
Okay, so University Hospitals of Leicester, we are graded as a level 2 trust, which in the land of organ donation means that we have more than 6 donors per year and less than 12. So far this year, we're up to 9 donors. Last year was incredibly high. We had 17. And the COVID year, unfortunately, we had 3, which was seen across the country, really a dip. Normally every sort of 2 to 3 years, the levels are looked at again. So we've got a levelling meeting, which will be about next June. And despite our numbers pre and post COVID being at a level 1, we will still remain a level 2 because of the COVID year, which is sad, but we'll just have to keep getting high numbers of donors. So this meeting was supposed to be in December, so it's slightly out of date now, but this is the last sort of ratified numbers on the trust report. So that said, we'd had 4 donors in the first 6 months of 2022. That was 1 DCD donor and 3 DBDs. Like I said, we have now moved up to 9. And the organs transplanted, we transplanted 8 kidneys and 3 livers. And if we just look at the DBD pathway, you can see blue represents the Leicester Royal Infirmary. So the Glenfield didn't have any donation after neurological death. But the Royal, they suspected and referred 9 patients. They tested 7 of those. 7 were confirmed. Just 5 were eligible for donation. We approached 4 of those, and 3 were consented and 3 became donors. If you look at the DCD pathway for the first 6 months of 2022, The Glenfield did get some activity. So 12 DCD patients were referred for the Royal compared to 8 for the Glenfield. Both approached 4 families. 3 were consented at the Royal and 2 were consented at the Glenfield. Just 1 resulted in a donor at the Royal, and that would be because the 2 at the Glenfield didn't die within the time frame, and I think the other one, the consent was withdrawn because of the time frames. So the organ donation time frame from consent to retrieval varies massively depending on the amount of organs that you're trying to match, but on average it can be between 20 to 30 hours, and so this family specifically needed a patient to die in a certain time frame for them, and that didn't happen, so the consent was withdrawn. And our lovely senior leadership team love to look at rates. So they look at these rates, referral rates, consent rates, and the SNOD presence rates. We hear a lot about, was there a SNOD in the room? Why wasn't there a SNOD in the room? There's lots of questions regarding this. So if we look at the DBD side, which obviously only relates to the Royal, we've got a lovely 100% referral rate, quite a high consent rate there, and 100% of SNOD in the room. Which is fantastic. On the DCD side, still fairly good to be fair. We've got 80% referral rate for the Royal, 90% for the Glenfield. Again, the consent rates are fairly good, but we haven't always got a SNOD in the room for those cases. And it seems to be on the DCDs nationally, not just within our region and our hospital, but where those conversations quite quickly slip from futility straight into end of life, and we don't get involved and miss those opportunities. Tissue donation. So tissue donation is a bit of a forgotten sort of poor cousin really compared to organ donation. Our role, as it says, is a SNOD, a specialist nurse in organ donation. For Leicestershire, we don't have a tissue donation specialist nurse. We are starting to see some across the country, and maybe in the future with more funding you will see nurses specifically focusing on tissue donation, but as it stands we sort of pick up this role. So tissues can be donated from anybody following death. So anyone who dies we could consider this for. There's a national referral centre where we can refer to 24 hours a day. The patient needs to be transferred to the mortuary fairly quickly within 6 hours to preserve those tissues. Most of them are retrieved within the mortuary, and tissue donation is life enhancing rather than life saving, and families can receive follow-up as well. So there was a lady a couple of years ago at the Royal, some of you may remember her. She unfortunately hung herself. She went on to be an organ and tissue donor, and about 7 months after her death I had a call to say that the heart valves that had been stored at Birmingham Children's Hospital had been used in life enhancing surgery for 3 babies. And it was really nice to be able to ring the lady's mum to explain this to her. Unfortunately, the lady who'd hung herself had left behind 3 children, and so when I explained that the heart valves had been used for 3 babies, she found this particularly symbolic and powerful. And so I think it's important not to underestimate the power of tissue donation. Some people, organ donation gets all the attention and tissue donation is very much left behind.
So corneal donation is a specific one that NHSBT are pushing people to think about at the moment. Our corneal donations post-COVID have been very much reduced, which have really impacted on the amount of transplants that we can do, amount of operations. And what we're finding is a lot of people have been cancelled and having to wait much longer, just because we don't have a supply. So when we talk about corneal donation, when we donate eyes, we remove the whole eye, because can actually happen is you can help up to 6 people with one pair of eyes. So the corneas can be donated, but also the sclera can also be donated to a couple of different people, and that can help people in different ways. So one pair of eyes can help 6 people see. So it's really, really, really important that we are offering this to our families. So when we offer tissue donation, what do we mean by that? So the first thought is, are they ventilated? If they are, please refer it to the organ donation team. If they aren't suitable for organs, then we'll let you know that, and we'll let you know what tissues they are suitable for and what to discuss with the family. If your patient isn't ventilated, then you don't need to refer it to the organ donation team, but you can discuss tissue donation with your family. So when we do tissue donation, we usually talk about it when we're giving the bereavement books to the next of kin. There are leaflets on tissue donation in the SNOD office to give to the family, and what you would say is something like, I don't know if you're aware, but the patient was in a position where they could help improve the lives of others through tissue donation. Something you ever thought about, and would you be willing to discuss this further with a specialist nurse? If they say yes, please, then confirm which number is the best number for the nurse to call them on, and give the National Referral Centre a call, and they are based up in Liverpool, and they do all of the consents for tissue donation nationally. And you just call the number, press option 1 and leave a message to basically say you've had a conversation with the family and they would like some more information. The NRC won't ever cold call relatives without us making that first approach. And then you just call the NRC again when the patient's been transferred to the mortuary, just to confirm that it's within 6 hours of asystole, and that's it. But if you are unsure of anything that I've just gone through, please call us if you are unsure, and we can talk you through it. Don't mind. And that is it. Thank you.
Any questions on organ or tissue donation, or any specific cases while we're here? Hopefully you can still hear us.
We can.
Oh, that's good. It's always good when you get to the end and they go, "I've not been able to hear you."
No, we definitely can.
You know.
I had a question. What other people think? When you're talking about circulatory death donation after circulatory death, and you're doing withdrawal of life-sustaining therapy, do you guys have any preferences to, obviously it's dependent on the patient dying within 4 hours, do you guys have any preferences to whether they're extubated or not?
So if generally what you find is if you leave an airway in, then
they keep breathing.
They keep breathing because
Yeah.
they have an open airway, and they won't die within that time frame. So if your goal is to make it last quite a long time, then organ donation really isn't suitable, and we'd probably have that discussion quite early on. If you know, when people have tracheostomies, clinicians sometimes feel quite uncomfortable about decannulation. That is sometimes a discussion with the family of actually what they want to happen, and generally if there's no decannulation, then they're not going to die in that time frame. So it would be unkind to offer the family something that we couldn't achieve. Generally, well, sometimes families, even if they have had neurological death testing, they would still like to be there when the patient's heart dies. So normally they would go transfer to theatre on the ventilator, and then their heart would stop during theatre. Some families would prefer to be there. If you know that they're not going to breathe, and you know you really wanted to leave the tube in, then you know that wouldn't really have any effect in any way. And I don't think we would really mind. Normally it's for the kindness of the family that they get to see their patient's face, that haven't seen in a week or two, and actually they get a lot of comfort from actually seeing them with no tube. So I always advocate for the NG tube to be taken out as well, just because then they get nothing on their face. And actually I think that is really important. So it's yeah, it's an interesting.
It's difficult. We have had a situation recently where a patient was extubated in the anaesthetic room and the anaesthetist put in a Goodell airway and oxygen, and the patient didn't die within the time frame, which was obviously disappointing for the family. But, you know, it's difficult because you're not there at that time, and it's a clinical decision for that patient at that time, maybe based on comfort or distress, or so I think it is a bit of a tricky one about which is why it's really important to have that the withdrawal plan documented, so there's no conflict of interest between our aims and your aims. It's your decision, and we'll follow whatever's documented.
Yeah, if they're on lots of NORAD or something, it's really easy because they'll stop quite quickly. But if they're not, then you kind of have to take organ donation out of it a little bit and do whatever the family want you to do, don't you? And taking the tubes off their face is definitely helpful. Even if you take the tube out and put them in the recovery position so they don't immediately obstruct and die.
Yeah, I think it's like you say, I think it's about good end of life care. First, regardless of organ donation. It's not organ donation at all costs.
And we wouldn't put them in a position where they're going to occlude their airway, because you know, we don't agree with
it. It looks bad if we take the tube out and then they immediately.
Yeah, it does. You know, we're not that unkind. It's not donation at all costs. No. It's end of life care, and if they die within a time frame and that's what the family want and the person wants, then we'll try and facilitate it.
The other thing I was going to ask, I've never actually asked about tissue donation ever. Do I ever ask it?
Well, I think it's something that's just missed nationally by everyone because it's nobody's role, but I think it's everybody's responsibility really just to ask, would you like a call from tissue services with any person who dies anywhere, community, hospital?
I mean, unless they have, you know, a blood cancer or cancer of the eye, or you know, Parkinson's or something like that, you know, that's literally the three things that you need to remember. Anybody else can. I think somebody was 107 and they donated their eyes. I think that's the very oldest, you know, so just to put that in there, you know, you're wondering if they're too old.
Well, the nurses tend to give the bereavement booklets to the family at some point during the end of life process.
Yeah. And it is something we're including on the new starter ITU training for nurses, but I think it is all about a collaboration of let's just hope somebody mentions it.
And if you do feel that it's something that you want to discuss with the family when you are talking about end of life care, then please do, you know, absolutely do. Offer it to them and just call the guys at the referral centre, and they will talk them through everything.
Yeah. Does anybody else have anything to ask?
I think Cindy was going to say something, weren't you?
Yeah, go on, Cindy.
So I think there's two things that I wanted to add. One is, I think the earlier you get your SNODs involved, when you are starting to have the futility stroke end of life conversations, even if they are just in the room as support, because they are at the end of the day specialist nurses, you know, with an interest in end of life care, and they will support the families and they will support you and also our unit nurses. So the earlier they're in the room and that the families get to know their faces and accept their presence as something that is standard is really, really helpful. Even if you have to have a few more conversations and get them in the room, they'll be quite happy to come. The second thing is, if there are any concerns, if you are worried and you're not sure what is happening, there are 2 clods in our trust. Please just call us. I don't care what the time is. I'm always happy to be called. I think Ricky is as well, but he has got a baby, so you know.
He's on the call as well. You're there, aren't you, Ricky?
No, but I mean, if it's like after midnight, probably better to call me. But we are very, very happy to be involved and to help wherever we can. That's it.
Thank you. Jenny?
I'm going to move away from my very noisy husband. Apologies about that, guys. I didn't realise he was not on mute. I had a question. I just wanted to clarify the situation regarding COVID, and also there was a question about long COVID and whether long COVID patients could be donors. That somebody asked, and I thought, oh, that's interesting. I don't know the answer.
So
Yeah, I mean, any patient with an incidental finding of COVID can be a donor. They just donate their lungs if they've got an active COVID, because they have found to pass that infection to the recipient. Long COVID, if the organs are working, then it shouldn't be a problem. Obviously, if you do have organ damage from COVID, then they wouldn't be donated anyways. But any incidental finding of COVID is still, please still refer to us. Did that answer your question?
Yeah, it did. Thank you.
Okay.
I think there's quite a few people in the long COVID community that are sort of thinking about taking themselves off because they're worried about passing it on, which was
oh,
really
really? I haven't heard that.
Yeah, it seemed to be doing the rounds on COVID Twitter a few days ago.
Oh, I didn't realise. No, that's not.
No, they only found it transmissed in lung donation when they didn't do a ET aspirate, when they didn't find the COVID from an ET aspirate, and then they transplanted the lungs, and then they passed on the infection. But other organs are fine.
Thank you.
So far, I mean, you know, still very new. We'll see.
Yeah, if you're 28 days post-COVID, they'll look at your CT levels, your viral load, and have a look at where the infection is, and make a decision with the virologist.
Cool. Does anybody else have anything they want to bring up or ask? If not, thank you very much, guys.
You're welcome, anytime.
Thank you.
Hope it goes well at Glenfield for you.
Thank you.
The paper we're looking at today was published in Intensive Care Medicine earlier this year. Well, no, sorry, last year now. We are in 2023. And it's looking at the long-term outcomes of using a higher dose of dexamethasone than was used in the original recovery study, and is what we've been using ever since early 2020. So all good research starts with a question. And the first thing they did as part of this study, as far as I can understand, and this image is actually from some of the additional online data, was look at what clinicians thought should be the daily dose that you would use in COVID. Now, just over half were saying 6 milligrams, but there was a significant number of people who felt that it should be more. And I don't know why they chose 12 rather than 8, because most people seemed to think that 8 was a better dose, but then I suppose it's not hugely bigger than 6. So they did indeed go with 12. Now, this was investigator initiated, so not driven by drug companies, because at the end of the day, dexamethasone is cheap as chips and the drug companies probably don't care if we use 6 or 12 milligrams. It was an international study over several countries in Europe and Asia, and it was both blinded and centrally randomized. So the initial study design was very robust. They planned to enroll 1,000 hospitalized adult patients, and I think their initial power calculations were probably done on the mortality rates earlier on in COVID, which I think may have caused issues with this study later. But recruitment was 27th of August 2020 to May 2021. Now, to put this in context of the clinical situation, this was after we'd started using dexamethasone regularly. across the world, but probably before a lot of our other big treatments had come in. In the UK, certainly by this point, we were using tocilizumab, but I'm not sure it was as widely taken up in other countries. So there are a number of trial protocols that you need to look for when you're looking at studies, and each design of study has different things. So the Spirit guidelines ensure that you've ticked off everything for an interventional trial, and the Helsinki Declaration is the international ethics guidelines that mean that everyone is doing what they should. So as I said in the design, it was a 1-to-1 ratio that was centrally randomized in Copenhagen. So the trials units had no idea who was going into which, with the pharmacy staff preparing the trial medication and then having no further input into the patient care. So this was open to all adults over the age of 18 who were positive for COVID and having invasive ventilation, NIV, or with high oxygen flow rates. This is based on the fact that the original recovery trial dexamethasone arm showed that dexamethasone did not confer an advantage in people who didn't need oxygen. And the more support that you received, the bigger benefit dexamethasone seemed to have. Exclusion criteria was obviously allergy to dex or use of other steroids and any infection that might not be helped by having high dose of steroids on board, as well as the usual, we don't do studies in pregnant women. So the characteristics they looked at were all of the usual. Now, although they said that inclusion criteria were all adults over 18, they did in fact stratify based on age being under 70 for all of their analysis, probably relating to a significant difference in mortality at that point. And all of the other things that are listed there are basically things that would impact your mortality anyway, so they're things that you need to adjust for in an analysis, and they all make sense. Their primary outcome was days alive without life support at day 28, which is not the same as the number of days on ventilation, full stop. So that was an interesting point that they made in some of the secondary analyses. So just one to remember when reading through. But they've defined life support as supporting any of the major circulatory, renal or ventilatory systems. Secondary outcomes were interesting because, of course, we've seen in our COVID population the impact that it has longer term. And in fact, something that we talk about a lot on ICU is, well, we can get them through this acute illness, but what is their life going to look like after that? And it was good to see a study that did at least try to look at what is the quality of life of these people, getting them through the acute illness, and is it improved by having the higher dose of steroids? But also the fact that a lot of studies look at 30-day mortality, and some patients make it out of ICU but never make it out of hospital. So lengthening both the mortality measurements and the health-related quality of life measurements makes a lot of sense in the context of COVID. So they published their statistical plan beforehand, which is very good. They performed analysis on all randomized patients, but they published results from patients who hadn't got protocol violations. So a protocol violation was where a patient accidentally received open label steroids rather than the study drugs on more than one occasion. And then they looked at significance of 95% for primary outcomes because that was what the study was powered for, and at 99% for secondary outcomes because of the sort of issues with those. So they aimed to get 1,000 patients randomized, and at that point they stopped the study. With all of the people who were lost to the study at various points, they ended up with 980, oh, can't remember, 980 something, 982, there you go. And I just wanted to make a note in terms of the size of this study that in the dexamethasone arm of recovery, there were 4,000 in the usual care arm and 2,000 in the dexamethasone arm, which just shows the difference in size of this study and one of the reasons why it might not have reached significance. This was just a quick breakdown of the patients who were recruited in the end. The differences between the countries, Denmark and India, in terms of their mortality rate, appear to be much worse than Sweden and Switzerland, but I believe that was more related to their issues with recruitment in Sweden and Switzerland. And if you look at the numbers that they've got, it looks like there might be some skew there, so probably nothing to worry about. But that just gives you an idea of the populations with quite a lot of comorbidity and with fairly similar amounts of limits of care, invasive ventilation, etc. in the two groups. So fairly well matched. But I did want to say they didn't give you much individual information about the patients. So comparing it to what we've had before, this is the information that you got in the recovery trial. So you got much more about age, distribution, race, and all of the things about the respiratory support received and each individual coexisting condition. So it's an interesting one in terms of where you can then apply it, because the more information you have about a study population, the more useful it is going forward in both being able to compare it to your population and comparing it to other studies. So the mortality curves do show what appears to be a difference between the two arms, particularly between days 20 and days 60. After that point, the curves are very similar. But unfortunately, this does not reach clinical significance, not clinical significance, sorry, statistical significance. But there is a clear difference there visually. Now, the quality of life graph at the bottom, I think the bid and bold says it the best. Red represents worse outcomes and blue represents better outcomes. So more blue equals better, and there is visually more blue in the 12 milligram arms than there are in the 6 milligram arms. But that's broken down a bit more in the next slide, where you have the different measures. So health-related quality of life is split into mobility, self-care, usual activities, pain and anxiety, depression. So they're able to look at where there were any differences between the two groups in each of these measures. And one of the issues here was if a patient died, they assigned them as having a quality of life index of 0, which could possibly have skewed results a little bit, because then you are using mortality as part of your quality of life measurement. So it was one of the points that they mentioned in the paper, and just something to be aware of when looking at things like this. So they didn't find any statistical significant differences in mortality or their quality of life measures. They did feel that there was some improvement in the 12 milligram group. They do mention other studies in the paper. One of them was an open label trial of 200 patients that looked at decreased clinical worsening at day 11, which is a very odd measure, and found a significant difference. But I think if you pick a measure that you think will fit your study, then sometimes that can be an issue. And the other one was looking at ventilator-free days by day 28 and didn't find a difference. It is the first large international interventional trial to report long-term outcomes in patients with COVID. Most other trials have gone to 30 days or discharge from hospital. It was a good study design, and a good proportion of patients had their data reported and analysed, and they followed all of the usual checklists. However, the quality of life measures that they used haven't been validated in the COVID population, and because they have no baseline data for Switzerland, they had to apply German values to calculate what they would expect index values to be for Swiss patients when they were looking at quality of life. Because there was 6% of patients had missing data, they used multiple imputation to fill in the blanks, which is never a perfect approach, and only 10% of trial patients received interleukin-6 receptor agonists at baseline, which, as I said earlier, was not the case in the UK population at this time. So generalisability is a bit difficult. Also, they didn't have any report into incidents of serious adverse reactions or anything relating to the known potential effects of high-dose steroids. So were the diabetics made worse? Were there more infections in the higher dose group? Those things were not reported on in the paper. Having had a negative study, they did go on to do a secondary Bayesian analysis of this to look at whether there was a higher probability of benefit with dexamethasone 12 milligrams versus 6 milligrams, and they did manage to get that one to be significant. So just as a reminder, this is what the current protocol is for COVID in the UK. It's a bit vague, and I think centres are pretty much left to make up their own mind what dose of dex that they want to use, although I know most places still use 6, and it's important to remember all of the adjunct medications as well, and in which situation to use them, although all of our patients come into the high flow oxygen mechanical ventilated group. And then please don't use any of these. So that was that. An interesting study, I think, but with a few flaws. And I think it's interesting to go back to that first slide about where people think we should be using dexamethasone, and whether there would be any value in increasing the dose that we use regularly. So, any thoughts?
Is it going to change what you do you think?
I don't think so, because I don't know. It's the lack of reporting the downsides of using steroids, and the potential adverse side effects that I find slightly disturbing about this one, because they stated in the initial protocol that they were going to collect loads of information about adverse events, and they listed loads of things, and then none of it's reported, which always makes me a bit suspicious in a study. So without that, I wouldn't want to change what we're doing, because we have all of that information from what we have been doing, and you could potentially be making patients worse long term for less benefit.
Yeah.
So,
And it's odd that they didn't report it. Nearly everybody that was on ICU had diabetes, didn't they?
at some stage, yeah.
It does make sense that their sugars are going to be more difficult to control if they're on higher doses of dex.
If they didn't start off with diabetes, we gave them fairly rip-roaring blood sugars at some stage.
Yeah. Yeah, I know we use 6, and I'm pretty sure that Glenfield, I don't know if there's anybody there, but
we use 6 at Glenfield.
Did they?
And in Nottingham
as well sometimes, maybe. But yeah, we never really did. We talked about it, but never actually did we ever use 6.
I wouldn't be surprised if the occasional patient got something thrown in as a Hail Mary at some point.
Yeah, that sort of thing did happen quite a lot.
But then that happened in a couple of the studies I looked at, where one of the reasons that one of them was negative was because the clinicians were allowed to escalate to 12 milligrams if they felt it was in the patient's clinical best interests, which is great for the patient, but not so good for the study.
And it usually, we don't know what else to do, so try it as a last resort. Yeah.
It's like methylpredin respiratory patients.
Yes, very like. We use that too. I find it very weird. Just before Christmas, admitting somebody to ITU with COVID pneumonitis. It was like going back in time.
We almost got someone a few weeks ago. There was a young lady who ended up under respiratory, and I think I was chatting to one of the respiratory consultants about it, and he managed to get to her in ED and give her all of the usual COVID drugs, and it started to turn around just in time to stop her getting to us, because she got to 60% oxygen before she got any of the COVID drugs given to her, because ED was a war zone. And it does make a big difference though.
Yeah, that's good. Well, thanks for doing that, Sarah. It's good, and it's useful to have a refresher probably, because most of us are in trying to pretend that it never happened, I think.
Rocking in a dark corner somewhere.
Yeah, something like that.